Perspectives in Oral Health is a presentation of Tufts University School of Dental Medicine's Office of Continuing Education. Join us as we engage with leading experts, healthcare professionals, and thought leaders to unravel the latest advancements in science, dentistry, and the interconnected relationship between oral health and overall well-being. Without further ado, here is your host, Dr. Imran Asim.
Hello, Jumbos. This is Perspectives in Oral Health, and I'm your host, Dr. Imran Asim. Today, we have the Dean himself, Dr. Karimbux is here, because we want to give you perspectives from everyone, and what better way than to start at the top with Dr. Karimbux. So thank you so much for joining us today.
Yeah, I'm really excited to be here.
Mm-hmm. So for those young people who are watching this and want to be someone like you in charge of a dental school, how would you advise them in their career choices?
I would say that people need to be excited really about what they're doing. And, my journey basically was one of being excited about what I did throughout my career. When I first went to dental school, I really didn't know what I wanted to do. I had a very open mind. And my choice to become a periodontist was based on the fact that I did 2 years of medical school at Harvard School of Dental Medicine. And the medical model of disease is what excited me, whether it was thinking about chronic illnesses, acute illnesses. And so that led me down the field of periodontology, because as we know, periodontal disease has both a bacterial component and an inflammatory component. Mm-hmm. In the clinics, it was really exciting to learn about surgical procedures in perio as well. We had to do, actually, as pre-docs at that time, 8 perio surgeries. And, once I was in the perio program, the next piece was that kind of opened my eyes to all that dentistry has to offer, had to do with research, and I got involved in research. And I enjoyed the clinical components of my residency. I enjoyed the residency pieces, and the final kind of key for me to go into academics was interacting with students. As second and third year residents, we had to teach pre-doc students, and I just loved interacting with students. And that's really what led me down the path of becoming an academic.
Yeah, it keeps you young, I feel like.
Sure. I mean, even as a dean who's in a very administrative position, walking around and seeing the development of students is really what kind of keeps me motivated.
Yeah, that's huge.
And seeing the interactions between the faculty and the students as well.
Mm-hmm. So I want to share one of my favorite Dean Karimbux stories with you. One of the first years that I was here as a faculty, I was coming in and I was wearing a hat from my old alma mater, which is the University of Florida. And I'm a big Florida fan because it's almost like a religion to be involved with the sports. And you called me out and you were like, why are you wearing that?
Right.
like you should be wearing a jumbo hat. And it was like a little mind virus. I went home and it just I'm like, why am I wearing that? I'm a professor at Tufts University now. I should be representing the school. So that was the day that I became a jumbo, And so I credit you for that. But I want to know what your first jumbo experience was, because you've been at Harvard, you've been at Tufts, you have a lot of different backgrounds that you can identify with. When did you first feel like you were a jumbo?
I'd spent almost half my professional life at Harvard, both as a dental student, as a resident, and then almost 20 years as a faculty member. Mm-hmm. And, moving to Tufts, it was the right choice for me at that point of my career. Mm-hmm. But what I worried about when I first came to Tufts was losing the intimacy of what is the smallest or one of the smallest schools in the country and coming to what is the second largest dental school in the country. And those anxieties and fears, I would say, were put to rest pretty quick. Because as soon as I came to Tufts, I heard about the Tufts family. Mm-hmm. And I was embraced by people really across the dental school. Mm-hmm. And I would have to say that the white coat ceremony that happened relatively early on in my tenure here is what kind of sealed the deal. Mm-hmm. Because the President Monaco at that time actually came to the white coat ceremony. And any of you that have been to white coat ceremonies or graduations where you've got 200 students know it's going to be about a 3-hour affair. And to see the president at that event spending time with the dental school and the dental students and their families really sealed the deal that, this is part of what it means to be a part of the Jumbo family. And those are the kinds of examples. I found Tufts to be a very collaborative environment, not only within the dental school, but really across the campuses. So, like I said, it was the initial embrace that I had from the community here, but also things like seeing the leadership from the university at events at the dental school that made me finally feel very quickly that I was a part of the Jumbo family.
Yeah, one of the things I like about you is that you go around to all the different social organizations, like the Perio conference that you just came from. I know that you were at the American Association of Oral and Maxillofacial Surgeons, and each one of those places you have that Tufts family that you kind of interact with,
Right.
and especially the alumni, which is really cool. And that's something that I didn't realize was available to me. And it's only now that my private practice is on the North Shore of Massachusetts, and you have all these Tufts alumni.
Right.
And when I tell them that I, teach here, your name always comes up. Like, you are the guy that they know about. And one of the things that I always hear from different people is, man, he's so forward thinking. Why do you think that people say that about you?
One of the things that has driven me throughout my career is having an inquisitive mind. And, having done research as a DMD student and then as a Perio resident, that really opened my eyes to questioning what are the norms. Because when you do a research project, you're really posing a hypothesis, and then you're trying to solve that hypothesis. And, to be described as forward thinking, I think you've just got to have an inquisitive mind. You've got to keep asking the question, why are we doing things the way that we're doing them, and try to answer them. And some of the best questions come from people that I interact with. For example, at Harvard, oftentimes students would question why we were doing things a certain way. One concrete example is the students at Harvard spend 2 years with the medical students. And when I was a young faculty member, we switched from what was a lecture-based curriculum to one that involved group thinking and group exercises. That was first instituted at the medical school. Very quickly, students came to us and said, why are you at the dental school still teaching in a lecture-based format? Which is very passive learning.
Yeah,
The
absolutely.
formats they were in were active learning, thinking about clinical cases, applying their thoughts and knowledge, and looking up stuff. So I would say that, the answer about being forward-thinking is just having that inquisitive mind, which, can lead to a certain amount of creativity, can lead to what you've described as being forward-thinking.
So what are the big questions right now that you think that dentistry faces when you are having your curiosity going off? What are the questions right now that you hope that maybe the next generation of dentists cover?
I mean, being in academics, there are 3 or 4 things that we worry about. At the top of our list is recruitment and retention of faculty.
Absolutely.
The second is the sustainability of our dental education models because of the cost and the way that we run our clinics. There's a very thin margin, so to speak, because of the inefficiencies. The third thing that we think about is certainly diversity, equity, and inclusion. For the faculty piece, we are lucky in a way at Tufts, which is a private institute, to allow people to practice on the outside. So those that love both the academic side of things, which is the teaching and the interaction with students, doing a little bit of research, you can certainly achieve that being here. But we recognize the reality of living in a city like Boston. So allowing our faculty the flexibility of being able to practice on the outside, I think is, gives people that balance that they can have.
Absolutely.
We also have people that volunteer or come in half a day a week, and it's that blend of things that allows us to kind of try to resolve that issue. Here at Tufts, we also have what's called a faculty DMD track. So if you're foreign trained, if you've been here a couple of years, you can actually enter a formal curriculum to get your DMD. So those are some of the creative, innovative ways that we try to solve the issue around faculty recruitment and retention. In general, I think we're seeing a changing world around us, right? We've gone from a majority of people being in private practice to more and more students joining organized kind of corporate dental offices. And, I think what we have to do in dental education is prepare our students for that future. What that means is not having a traditional practice management course that talks about, the future being solo private practice. There certainly is an avenue for that still, but telling students that you also have these other career choices. And some of that goes back to when I started dental school. I was told, you can certainly come to Harvard and become a private practitioner. Many people have done that. But if you come here, we're going to open your eyes to all that a career in dentistry has to offer, whether that's research, academia, public health, fields like oral radiology, oral pathology that people don't traditionally think about. And so what I would say we have to continue to do for our students, for the future of our profession, is basically tell them that, when you come to any dental school, typically you're coming with kind of a wide lens in terms of liberal education. And a lot of you are driving towards a very narrow end, which is I want to be in private practice in a clinic somewhere. What I would hope we can do is basically broaden that. So you come in, with a certain background, but that we're opening up all of the career choices that you can have in dentistry. And I think that's what we've really got to do for this future generation of oral healthcare providers. We tend to label, I think, each generation of students as well in a certain way. This generation gets labeled as being not as hardworking in quotation marks. When I went to dental school, I did 50 crowns. Now these students are not doing as much. We have to change that perspective as well. These students are motivated. It's still very competitive to get into dental school. They're the future of our profession. And how we mentor them and tell them about all that dentistry has to offer is upon us. What I see in students when they're in dental school is a certain passion that I didn't see when I was in dental school, to want to be engaged, to want to do good for the community, to be civically minded as well. And so it's certainly a different generation. They've been brought up very differently in terms of technology. The way they interact with the world is very different. And we have to understand that and foster, their interests.
So I just want to double click on that for a second, because I hear from all the different faculty that they feel like the dental students are much more competitive than it has been in the past. The rumor, and I don't know if this is accurate, is that it's much more competitive to get into dental school now than it was in the past.
Right.
Is that objectively true from your data?
Yeah, I would say it's kind of cyclical. For example, in the mid-'80s, when I applied to dental school, it was almost 1.2 applicants to 1.
Oh, wow.
Past 5 years, it's been almost 2+ to 1 to get into dental school. And what we're seeing is that there are some people that are kind of later in their career that decide to come back to dental school. So many of those students are getting master's degrees in order to be deemed to be competitive enough to get into dental school. So, for example, the last 2 years at Tufts, almost half the class has had a master's degree.
Oh, wow.
But that also speaks to underrepresented minorities, sometimes that might not be looked upon as being competitive from an academic grade perspective. What we found is a lot of those students will go and get a master's degree and then be very successful in dental school. So to a certain extent, I would say it is more competitive. Again, these things are cyclical. What we expect of students in terms of their background as well is changed. When I applied to dental school, to be honest with you, I had not really shadowed a dentist. I was told by my principal in high school that dentistry's a great career choice for someone who's doing well in the basic sciences. In general, I would say, this population of students has researched what it means to be a dentist probably better than in the mid-'80s. And, I think the portfolio that they have to get in terms of community service, What examples do you have of leadership ability? All of those things, I think, make a well-rounded applicant. And so now I think you're seeing students with, kind of that portfolio that are applying to dental school, which certainly can make it more competitive. I also see many students that don't give up on their dream. Students that don't get in the first year will apply the second year, will apply the third year. And, there's some resilience and persistence in that kind of a student as well.
Absolutely. Yeah. No, I totally agree. So I feel like their aptitude is so much more stronger than when I was in dental school. Like they're so sharp, they're so engaged, just like you were saying.
Right.
So those combination of factors is something that's really interesting to watch because, you tend to look at everything as a monolith, right? Like everybody's the same, but then you have all of these different experiences with different students. And there's definitely, for me, I feel like a really strong applicant that's coming into dental school these days.
Right. The other issues I think that our students are dealing with is obviously health and wellness is a big one coming out of COVID. The cost of dental education is high, so sometimes I hear about students that are trying to balance a little bit of work on the outside, plus keeping up with dental school.
Wow.
The competitiveness I think is there amongst some of the student body because some of them know that they want to get into very competitive residencies right from the get-go. And, I think there's a certain drive amongst those students that might be different from other students that have other interests.
Yeah.
What we have to do, I think, in dental education is make sure that these students have the resources to be successful in a career that can be stressful. So, for example, at Tufts, I'd say we have a very robust health and wellness curriculum where from day one, we talk to them about practices that can help them, whether it's meditation or yoga, and it's integrated throughout the curriculum. And so those things I think are important to tell students, yes, it is about your career, but you also have to have a balance in order to sustain what, should be really a long career in oral health.
So I want to talk about just the choice between quote unquote academics and private practice, right? Because this is something that is a very difficult decision for many people to make. They are burdened with all of this student loan debt, and then they come out and they look at academics versus private practice, and it's very difficult to say no to private practice because of the difference in compensation. And I like how, especially at Tufts, there's a number of different ways of engaging faculty that are part-time or that have, like you said, working on different practices outside of the university. What do you feel like those lines are blurring more these days, or do you feel like the academic path is still pretty set in stone? Like if you wanted to be dean, would you still have to go this same route of academics versus just having the private practice on the side?
Yeah, I think most deans have kind of been full-time academics. Most of them, I would say, in general, have specialized as well. But we do see some deans coming from less traditional pathways. For example, people that have been in the military, perhaps, or on occasion, people that have been in industry that are making the switch. The path to becoming an academic, obviously there's a lot of different paths. A lot of people who specialize and get a master's degree or a doctoral degree or a PhD are almost committing to a full-time career in academia.
Yeah.
And, the specialist areas are certainly looking for faculty to want to be full-time. And once you're in that track, there can be a career ladder that allows you to become a leader, whether it's a pre-doc director, a program director, eventually a chair and or a dean. So for the most part, those are the typical kind of paths. We have a lot of foreign-trained dentists that come to the U.S. to specialize. Once they're here, they want to stay, but they can't necessarily practice without a DMD or DDS degree. So oftentimes we fill our faculty ranks with people that have become specialists in the U.S. but want to stay, and they can kind of practice under the umbrella of the university, and that's a great trajectory. I've seen a lot of foreign-trained dentists from all over the world, from India, from South America, from Europe, that have come in that way and had very successful academic careers. But we also see people that are getting close to retirement and want to stay engaged. Those folks can certainly come back in and be full-time faculty members. But at that point, I would say for them, unless they've had major leadership activities either within their dental societies or the ADA, they typically will be the assistant professor who's in the clinic teaching. So I would say that kind of describes the whole umbrella of our faculty. We have faculty that will also go from school to school when there are opportunities to kind of grow. So, for example, I moved from Harvard to Tufts because there were other opportunities here. And then, like I said, it's the people that are retiring that want to be full-time still. And, part of the benefits of being in academia are obviously you get to interact with students.
Yeah.
There's a lot of collegiality amongst the faculty on the clinic floor. You continue to obviously treat patients through the eyes of your residents or your students. And finally, you keep a university benefits package in terms of medical and dental and so forth. So there's a lot of, I would say, positives to being in academia.
Yeah, no, I think that it certainly has a lot of benefits. I think that it's just, if I were to talk to, so my whole family's in dentistry. I have a lot of family members, and they're all on this path of either applying to dental school, going into dental school, or in dental school right now. And all of them have already resigned themselves to private practice. And I'm trying to advise them that, listen, like, you should do this, you should do that. How would you advise someone that is a family member of yours that's in dental school right now that, listen, being a faculty member is very positive because of this, this, and this?
Right. We have a path here for students to delve deeper into what it means to be a faculty member. It's called kind of a career development track.
Oh, cool.
It's a little bit selective, but once you get in, it really gives students a deeper understanding of what it means to be a faculty member. So typically you'll get assigned to a mentor. You'll be told to go and interview at least 4 or 5 different faculty members across the spectrum. They can even come and chat with me about why I chose to be in academics. So I think through those kinds of experiences where people actually get to delve a little bit deeper in what it means to be an academic, you can really light a fire. There's always the practical aspect of obviously earning to pay back loans and to start off your career. But I think if you light that fire with those kinds of experiences, a lot of those people will come and revisit academia at some point. And I've seen people go into private practice for 2 or 3 years and then come back full-time into academics because they said, the opportunity to teach the next generation, to do a little bit of research, to do some admin stuff, have the flexibility of not being tied down to one location, but being able to perhaps move from one school to another. Those kinds of things, I think, once a person sees that and has that passion, it never goes away. So those are the things that I think people need to think about. I made a choice when I was in my perio residency to be a full-time academic. At that time, when I graduated in 1993, I had about $130,000 of debt. We were starting our family. We were living in Boston.
That's a tough choice.
But I made it because I had a passion for what I was doing. I made it work. Sometimes it meant practicing in the evenings and Saturdays, but I enjoyed all of that tremendously. And at a young age, I think I stayed on track in terms of saying I wanted to pay my loans off within 10 years. And no matter what setting you're in, whether you're in private practice or academia, once you're done with paying your loans, obviously you've got a lifetime ahead of you of being in a great career, of having the potential to earn a great living. And those are the balances that I think people really need to to think about.
Yeah. What I think is really cool about it is just the social aspect.
Yeah.
Sometimes in private practice it's kind of isolating,
Right.
like you're really only interacting with people at meetings, or you're the boss and then you have everybody below you, right?
Right.
So just that collegial aspect, I think it's underrepresented in the academic setting, because it is really fun to see people on a regular basis and talk about interesting things. One of the interesting things that I do want to talk about, because this is part of the continuing education department, this whole podcast, is some of the things that you speak about on a regular basis. The first of which is just the connection between oral health and systemic health, right? Especially, Perio has done a great job, I think, of advocating for this connection. I feel like it's this low-hanging fruit that dentistry really hasn't tapped into. Like, we've definitely tried. So, I hope that some of the people that are listening to this will take something away from the fact that there is a connection. But in your advice to those people, how would you tell to the patients, to the public at large, how would you help them make that connection?
I think you have to speak to it in terms that people understand. So I think there are some health professions that have done a really good job talking about risk.
Mm-hmm.
For example, 20, 30 years ago, I think people really didn't understand what it meant to have risk factors associated with cardiovascular disease.
Mm-hmm.
But nowadays, I think we're all versatile in the fact that diet, exercise, being on statins can improve, our cardiovascular health and lower our risk of getting strokes or heart attacks.
Right.
Similarly, I think dermatologists have done a great job talking to us about skin cancers, right?
Yeah, absolutely.
So what I would say is that we as oral health professions with our medical colleagues really need to talk to our patients about risk factors.
Mm-hmm.
Some of the most common obviously are smoking and oral cancer,
Mm-hmm.
Uncontrolled diabetes, and the risk for getting periodontitis. But similarly, we should be telling our patients that, having an inflammatory disorder, that if you have moderate to severe periodontitis, can be the equivalent of the surface area on the hand of your skin.
Mm-hmm.
What I would say is that, if you were a patient that had that was visible on your leg and you were a diabetic,
Mm-hmm.
I think the physicians would be all over you about you can't have that kind of inflammation.
Yeah. Right. If you had like this huge sore that was the size of your hand, every physician would treat that.
Right. And so I think what we have to do is really translate what we understand scientifically into layman's terms.
Absolutely.
Not only for our patients, but also our medical colleagues, so they understand that.
Yeah.
Being pregnant and having periodontitis or gingivitis as well can be a risk factor for preterm low birth weight babies.
Mm-hmm.
So how we message that at one level, I think, is important.
Mm-hmm.
The other piece is thinking about integrated health.
Mm-hmm.
We see our patients more often than our physician colleagues, usually twice a year if you're doing maintenance.
Mm-hmm.
And for us to talk to patients not only about the connections between oral health and general health, but to talk to them about general health where we can, whether it's blood pressure, diabetes. All of those things are becoming more and more accessible diagnostically.
Mm-hmm.
The question is, how to get reimbursed and how to integrate that all practically in our private practices. But I think that day will come when you might tell a patient, listen, we can do a screening for you in terms of diabetes.
Mm-hmm.
We're happy to do it for you. Or, you're here, let's do an HPV vaccine or a flu shot, since we administer those here.
Mm-hmm.
At that point, it's going to be a lot more convenient for our patients to get that kind of health care without having to do multiple visits. So how we integrate, how we really become a component of general health, I think, is something that more and more will become apparent, I think, with technologies, with integrated health charts, et cetera.
Yeah, I really hope that day comes, because I feel like to truly treat a patient holistically, you have to have that cross-pollination of medicine and dentistry, right? And I think that there's some models out there where, you have a dental clinic that is associated with like a primary care physician, and then their results are much better. Is that correct?
Right. Yeah, in general, there's been some good studies that show, that having integrated kind of healthcare systems is a benefit to general health. It can lower the cost of your patients. There have been some neat studies that show people that get frequent cleanings that are diabetic, for whatever reason, their general health cost is lowered. And we're starting to see insurance companies that will reimburse patients to get extra cleanings a year if they fall under a certain category. So those are the very practical things I think that we're starting to see happen now to improve one's general health in terms of taking care of oral health.
Yeah, I really hope that gains traction and ends up being what it is that you envision.
Right.
Because right now we're just so siloed, right? And that's one of the goals of this podcast, is to see other people's perspective, you know? So is to make sure that me as an oral and maxillofacial surgeon knows how it is to be a dean, so that I have a better understanding of just the dental field in general, right? So we're going to take a break here, and we'll be right back with the dean in just a few moments. So I want to share with you my second favorite Dean Karimbux story. So when I was scouting locations for this podcast, I was looking at this place, and I wanted to use the boardroom here.
Yeah.
So I just walked in, and you were in the middle of a boardroom meeting, and we locked eyes for a second, and I was just like slowly walked out. So that was really nice of you. That was very smooth. But what I want to know is how the donuts are made. Like who's in the boardroom meeting like that? Like when you have all these departments that are directly reporting to you, like what is that like, and who is sitting at that table?
You know, there's several different meetings that we have throughout the year, and I'm not sure which meeting you kind of stumbled in on.
Yeah.
But at one level, I meet with my chairs and deans usually once a month, just to give them information about, you know, stuff that might be happening nationally at the university level, at the dental school level. And it's really important for the chairs and deans, who are really the leaders of the departments and the units within the school, to meet and share issues and thoughts. The second group that meets in there is what we call the executive committee meeting, which is once every other month. We have a lot of committees here at the dental school that obviously work on a lot of different issues: compliance, risk, promotions committee, admissions committee. But each of the chairs of those committees comes together and gives everyone kind of a running report of what's going on. So, for example, the admissions committee right now is in the middle of the admission cycle. They might tell us about, you know, how many students applied this year, how does that compare to last year, how many students are we expecting to kind of admit, et cetera. So, you know, that it's important for the committees to kind of just update everyone on that status. Sometimes we have to do formal business of voting on policies and procedures that have changed. We also have to vote on each year's graduating class and send those names up to the university to make sure that, you know, everyone's completed their requirements and are eligible to get the DMD degree. Obviously, that's very exciting at that time of the year. And then finally, twice a year, we have what we call a Board of Advisors meeting. Each unit at the university has what we call a Board of Advisors. And these are a mix of people that are alumni, sometimes people from industry, that the deans really use as a sounding board. So oftentimes we'll give them an update of what's going on in the school. We might have a couple of projects we'd like them to work on independently between meetings. Typically we'll invite a speaker in as well that can speak to what's happening kind of nationally in the dental area. So I would say those are the three main kind of groups that I tend to meet with in the boardroom.
And when you're being a dean, obviously, are you practicing at all, or is that not? Is there no time for that?
You know, it depends on the size of the school and how much time you have. You know, I was a busy practitioner at my previous institute, practicing 2.5 days a week, in addition to being a full-time academic, and I really enjoyed that component of it. When I first came to Tufts, because it's such a large school as the academic dean, I did have one day to do private practice. But at that time, I also became the editor for the Journal of Dental Education, so I used my one day at that time to do that. You know, as a dean right now, I can't really commit to a fixed schedule to say, you know, Wednesdays I want to be in private practice. Once I became dean in 2019, I'd given up seeing patients, but I live through the eyes of others. So, you know, I sometimes work with master's level students on research projects. For example, when I was the academic dean, we actually worked on a very exciting project with a fish skin allograft that came out of Iceland. And we did some animal studies and eventually did a case series using that material. It's now been FDA approved.
Oh, wow.
And I've been able to write a couple of textbooks, one called Clinical Cases in Implant Dentistry, one called Clinical Cases in Perio. So although not directly seeing patients, I involved a lot of our residents and faculty here at Tufts to write each one of those chapters.
Wow.
And certainly editing those chapters has kept me in touch with some of the kind of advances which are really amazing that we've seen in clinical dentistry.
Yeah, I think that, just like society at large, we're entering this exponential growth phase, and there's so many interesting things that are happening in the dental space. One of the things I wanted to talk with you about, because this is something that you do a lecture about also, is periimplantitis, which is something that I think that certainly as an oral and maxillofacial surgeon, I'm interested in ending it, right? So if you could talk with us a little bit about what the pathophysiology is, and how do I stop it? Obviously that's a very difficult question, but if you could just indulge us for just a few minutes.
Yeah, so when we think about periodontal diseases, there are really two of them. One is called gingivitis, which is inflammation of the gums or the gingiva without affecting the surrounding structures. The other is periodontitis, which actually affects the bone around the teeth and can result in loosening of teeth, etc. Implants are not immune to both of those diseases. So, on the one hand, if you have inflammation in the gingiva around an implant, we call it perimucositis. But if the inflammation spreads down into the bone, we call it periimplantitis. What we found is that the mechanisms are very similar to that original disease process that I talked about. The bacteria are similar. The bone loss patterns are similar. The players that cause the bone loss, which is the host defense system, are very similar. But the differences are really in the uniqueness of the structures. So, implants have a direct bone-to-implant contact. And because of that, there isn't a ligament and as much vasculature that we see around natural teeth. So the bone loss patterns are very different. For the most part, they tend to be obviously isolated around the implant, but they can be very crater-like, we call them. They can be vertical in nature rather than horizontal. The other differences are that we have to understand the anatomical differences. So probing around an implant versus probing around a tooth, very different, again, because of the structures.
Right.
Seeing bone loss around an implant doesn't necessarily mean there's been bone loss, because there's a certain amount of loss that can happen within the first year of loading implants. So I would say that clinicians have to have a very good understanding about the commonalities and the differences, and I've just given you some examples.
Yeah.
The treatment as well is difficult because we don't really have, I would say, very good large clinical trials around implants. Obviously, natural teeth, it's easier to do. You have patients that have had a lot of disease, around 32 teeth. Each implant is very unique, both in terms of the individual that it's placed in, but also, where it's placed in the oral cavity, what the individual's risk factors are. Having said that, there's still some commonalities. If you're a smoker or a diabetic, you tend to be at risk for more bone loss around implants. But despite all of that, the best way to prevent disease is to make sure that, number one, you're diagnosing it. And there's a lot of offices, I think, that might ignore good diagnosis, knowing what the baselines are and the history around implants. So the fundamentals of diagnosis are critical. And then treatment is similar to what we do for our patients, which is scaling or scaling and root planing. If needed, surgical access to clean and try to regenerate, but also understanding how unique it is to lay a flap around a dental implant can be very challenging. In aesthetic zones, if you lay a flap around an implant, you're going to get exposure. So it's very nuanced in terms of each individual implant, each patient, each case. But fundamentally, we have to understand, like I said, what the diagnosis and treatment options.
How much do you think that the oral microbiome plays a part in that? Or is it mainly just local factors?
Like I said, most of the findings have shown that it is a similar kind of bacteria that cause gingivitis and periodontitis that are implicated around dental implants. What we don't fully understand, I think, is the nuance of kind of the implant itself, the history of how it was placed. I suspect at some point, knowing all of these factors and being able to enter them into some kind of a database, perhaps using AI, we may be able to come up with better kind of parameters about, in this certain instance, maintenance and leaving it alone is better than intervening and so forth. So hopefully, as technology continues to advance, not only will our diagnosis improve, but our treatment options will improve. And obviously, we've got a lot more armamentarium compared to when I went through the perio program in terms of bone grafts and membranes and all kinds of different treatments that can help us.
So one of the things that you just mentioned was AI, which I think is just now permeating into the dental community. There's a lot of other big things that I think that are being looked at from a research perspective.
Right.
One of them is the oral microbiome, which I mentioned. What are you most excited about that's coming down the pipeline?
I would say the ability to really integrate everything together. So, for example, we've gone from an era where we would do perio probing and record it on a paper chart. All of our caries and restorations would be put into a paper chart. I think the ability to merge all of that information together to better diagnose, understand disease patterns over time will allow us to really make what I would call more treatment choices that really take all of that into account, both from a preventive and a treatment perspective. The ability to also marry that to patients' dashboards so they fully understand what their pattern is. That's where I really see the value.
Yeah.
Having a smart watch, for example, that I just finally got last year. I would
Welcome
say
to the club, man.
I know. I would say it's changed my behavior in two specific ways. One is I make sure I get up from my desk and walk the 15 floors of the dental school much more than I used to.
Wow.
So I get my steps in. But it's actually, for me, also led to better sleep patterns. I would kind of
100%.
wake up, and some days I would be like, I don't think I got enough sleep because I felt like I was up all night. But now when I look at my watch, I can say, okay, I was up for like 30 minutes, but I actually got a good 6-7 hours sleep. And that just psychologically, I think, changes my demeanor during the day.
Yeah.
So anyway, I think it's that ability of taking information, marrying it into something that can be readable and useful for clinicians and patients that ultimately will help us prevent and treat disease a lot better.
Yeah. No, I agree with you about the smartwatch. I actually have 2 of them. So as soon as I take one off, I put the other one on. So I'm tracking everything. I'm tracking my exercises. I'm tracking sleeping. And it has definitely invoked a behavior difference on me as well.
Right.
I look forward to the day where we have something for oral health. I don't know if that exists right now, but I feel like it is something that we just haven't tapped into as a specialty.
Yeah, and the issue that we face is caries and perio disease are so multifactorial.
Right.
And right now we keep saying that we don't fully understand which factor is affecting which patient individually in which site. The ability to take all of those factors, put them together in some way that's going to be predictable of disease, that really is the key. And so I think that's where I see the value. From an education perspective, I see a lot of value. So if you're a dental student right now, I would say in general at any dental school, and you see your first patient, you have to take the medical history, take the dental history, get a faculty member to come over and certify it. You then start your intraoral exam, you do your charting, you have to have a faculty member come over and check. Take your radiographs, have a general dentist and a perio. So that creates a lot of inefficiencies. I would imagine a day where if you got the integrated health record, like Epic, you're certifying a lot of that information before your patient gets there. Very quick medical update that can be done through teledentistry to avoid having your patient to just come into the dental school to get that one step done. Once you've kind of entered your perio charting and or your hard tissue charting, you have the ability to look at it individually using AI that will match it to your radiographs and kind of test yourself in a way before you call one faculty member over to just verify stuff. So I see it creating a certain amount of efficiencies. I see it creating a certain amount of learning opportunities for students as well. For example, if you're looking at a set of radiographs and you're asking a student to identify caries and bone loss, and then after that you tell them hit the AI button and it's going to kind of identify the spots that the AI programs identified. I think there's a lot of value educationally from many of these applications.
Yeah, I think so too. And I like how there's some people that are adopting this wholeheartedly. Like a lot of people on the West Coast are now on Epic because of the DSO that they're associated with. Have you seen any schools that have produced any sort of objective data about this? Because you're in the dental education community. Anybody that's made that transition that has shown better outcomes?
I mean, there are schools that have adopted Epic because they're, the healthcare system they're in with the medical schools has shifted. I haven't personally seen any real outcomes in terms of has it improved either the oral or general health. Anecdotally, it's going to help both the medical and the oral health providers in terms of having a common kind of health history. Anecdotally, it's going to help residents that are in the hospital that are working in the dental school to make sure that information is captured.
Yeah.
The downsides, obviously, of all of these systems are the amount of time it takes you to enter data and make sure it's accurate.
Right.
So some of the downsides I've heard, it can slow down the administrative processes. Certainly, quite a bit of frustration from a physician's perspective of after hours trying to keep up with the amount of data entry points, et cetera. So those are some of the pluses and minuses. Obviously, the cost of implementing these things, every single technology is huge. And I think, we as dental deans have to make sure the technologies that we're bringing on board are sustainable within our environments. They're very different from huge healthcare systems. And so how we do that without necessarily passing the costs on to our students where tuition's already high is something that we really have to think about. Because technology is always changing and shifting. And if you've got to update your licenses and your technology every 4 or 5 years, especially in academic settings, it can be very challenging.
Yeah, it's certainly expensive. So one of the things that you talked about was the transition from a lecture-based format to kind of like a group-oriented format, which I think is not necessarily a change in technology, but it is an innovation in the dental education field. What are some other things that you look forward to in the future for dental education specifically, or education in general, that that is coming down the pipeline? Like, I have a 2-year-old daughter, and she right now has a robot friend that talks to her and just teaching her things, which I think is a huge innovation, right? Like that's not something that existed when you and I were at that age. But what are some things that are coming down the pipeline that you are really looking forward to from a dental education perspective?
I would say, efficiency of learning, customization of learning. When I went to dental school, we were still using Kodachrome slides. We all went to lecture. We took notes copiously during lecture without listening and understanding. We tried to reproduce diagrams because we knew we'd only see them once during that presentation. Fast forward to now where every lecture is recorded. Students have all of the PowerPoints. They've got a lot of resources on the internet. I think that kind of environment that students are in right now can also be very challenging. Where do you hang your hat on in terms of the information that you're getting? Because there's so many resources out there. I would imagine a day where, based on certain inputs that a student has, what they're viewing, how long they're viewing it for, there could be customization to having students answer some questions either orally or in some format that says, based on your portfolio and profile, you need to go and study the microbiology of perio a little bit more. So I think the inputting of that kind of information from a didactic, knowledge-based curriculum is going to help. We went through dental school at a time where you had to memorize pharmacology and drug interactions. Nowadays, obviously, with software and other things, it's becoming a lot more intuitive. There are a lot more checks and balances in what you can do. So instead of spending time having students memorize things, the question is, how do you apply these tools? How do you use these tools? And that's up to us pedagogically to design those settings where we give up having to lecture all the time, give up having to use multiple choice questions, but really put students in environments where they know that I used this tool and that wasn't the right tool, it was the wrong information, or how do I double check my information? Making classroom environments much more interactive. So using polling kind of softwares.
Yeah.
We've gone from using fill in the bubble multiple choice questions to using ExamSoft, which can not only
Sorry, I'm not familiar
ExamSoft.
with,
I'm
yeah.
sorry. All the students here at Tufts since 2017 have taken all of their exams on their own laptops.
Oh, okay.
So instead of having what I would call static exam where it's kind of multiple choice, you can put a lot of images in there, you can put a lot of videos in there, you can customize your questions. And you can also code your questions so that if I took an exam, I'd get my profile back again that told me that in general you did well in 6 of the areas, but you performed weakly in this one area, so go study that. In the clinical area, I think the ability of students to get feedback on the work that they're doing will continue to improve. Haptics and virtual reality will get introduced.
Yeah.
And again, I think using that technology, students will have a much better opportunity to get feedback on what they're doing procedurally rather than waiting for the expert or faculty member to come up and tell them, by the way, you should change your prep to make it more acceptable in this way.
Right.
I still see a lot of students waiting a lot for faculty to come and give them feedback. I see a lot of students spending their whole weekend in the preclinical area without getting that feedback. I mean, they're having to interpret on their own whether things are acceptable or not. But imagine being told that, after 3 or 4 preps, you're actually pretty good at this point, and getting feedback that you can really hang your hat on and say, yeah, I feel confident that I'm now at the step that I'm in, or having a virtual faculty member saying, by the way, you're in pretty good shape right now. So those are the exciting things that I think we'll start to see happening. And some of those things are obviously already happening.
Yeah. I love simulation. I feel like that was something that I really enjoyed in dental school. Like our sim lab was something that I really look back fondly as. And I look forward to the day where we have more of that and, less lecturing, which I think it has its place. I don't think that there's anything wrong with lecturing, but I do feel like that's where the true knowledge came for me.
Right, and some schools are being very creative in terms of gamification of things as well.
Yeah, exactly.
Obviously this is a generation that, for the most part, has done a lot of gaming.
Yeah.
And the question is, how do you make learning kind of exciting or kind of introduce that to a certain extent within your curriculums as well.
Yeah, I'm part of that generation, so I feel like when we can have a video game that is as fun as the traditional video games, I think that's going to be such a huge learning potential. So tell me, you have all of these things that you're doing on a regular basis. Like, what is the aspect of dentistry that you really, if it's a young dentist is coming up and they want to, be someone like yourself, what, other than like the dental aspects of it, things like character, things like, the non-tangibles, what would you make sure that they know?
I think no matter what training you get as a graduate student, whether it's a PhD, dental, medical, you do tend to narrow down because you're being asked to become a competent expert in a certain area or field. My advice is to keep your horizons broad. Yes, there are certain times in your career where you have to focus on certain things in terms of starting a practice, getting very confident with your clinical procedures. But don't stay within that little box. Try to broaden your horizons. There are opportunities that present to you in many ways that oftentimes you say, well, it's going to distract from what my main goal is. If you never pick up on those opportunities, you'll never kind of learn what's out there. You'll never learn a new network of people that are out there. So my charge would be have an inquisitive mind, step outside of your comfort zone, and continue to seek out opportunities other than what might be in your private practice area.
Mm-hmm. Yeah, no, I totally agree. And I would say that to everybody listening, that it's so easy to get siloed into our particular specialty or a particular practice. So go out and speak to other different specialties, speak to people like Dean Karimbux, and go to all the different other organizations that dentistry has to offer. And that's what we hope from this podcast, is that we have the different perspective, because there's so many different people in oral health that are contributing and making this field such a vibrant and interesting and important aspect of the healthcare field. So I will be having another podcast. I don't want to share with you just yet who the next person is, but if you wanted me to speak to somebody that's really interesting, that's contributing to oral health, who would you say in the dental school, just maybe top 3 that you would have on the podcast, so that the people that are listening today can have an interesting perspective?
You're limiting it to the dental school, not outside of the dental school.
I guess we could do let's not limit. Let's listen to Dean Karimbux's wisdom and not limit ourselves. Let's be broad about it. Let's not only the dental school. Who would you have me on
I
the
think
podcast?
The people that fascinate me the most right now are people that talk about leadership.
Mm-hmm.
And there are many people that have written books about leadership. They're experts in leadership. What I'm taking away from my career, even late in my career, that it's important to continue to think about those aspects. I mean, I've been obviously in a leadership position throughout my career, whether it's pre-doc director, program director, dean. But there's always skills that you can pick up on that are going to continue to help you to grow. Mm-hmm. So without naming anyone, I would try to get someone, and I can give you some names later on,
Sure.
that is an expert in terms of thinking about leadership.
Mm-hmm.
And, a lot of leadership is also kind of being open to being coached to a certain extent.
Mm-hmm.
There's one article that stood out to me that was written by a general surgeon. His name is well known to a lot of people, Atul Gawande.
Yeah, I've read his books.
And, he wrote an article in the New Yorker about him being a general surgeon.
Mm-hmm.
And observing, I think he'd taken his daughter maybe to the U.S. Open tennis, and he said, all of these guys are at the top of their field. I mean, number 1, number 2, number 3, but they all still have coaches.
Mm-hmm.
And so he relayed a story where he asked a retired surgeon to come in and actually watch him doing surgery, and as a coach. And he couldn't believe the tips that he got that have helped him improve along that way. And I think these people that are leadership experts can talk to people about tips like that in terms of what it means to continue to want to learn and aspire with that skill set.
So if I get somebody on the podcast that's an expert in leadership, what would you want me to ask them so that everybody could get some benefit out of it?
I would say just what are the life kind of skills that you think people at every kind of level can continue to pick up on and to learn? What are some of the main kind of things that person has seen in his field where he's had to or she's had to advise leaders? Mm-hmm. Presidents of universities, provosts of universities, deans of schools. Those are the kinds of questions, I think, that can kind of be enlightening sometimes in terms of, we all, no matter what level we're at, have our challenges. Mm-hmm. And hearing that we're all in this together, being a leader doesn't mean that you've got the answer to everything. And I think, one of the things that struck me is being able to also say, listen, I don't have the answer for that. Mm-hmm. It takes a team, and I'm going to kind of refer to one of my team members to do that. Here at the dental school, I think we've got a lot of people at leadership levels in the area of public health. Dr. Zavras has a very interesting perspective about not treating patients individually, but more thinking around, how do you treat a population and improve their health in general. Mm-hmm. So I think it would be fascinating to get a little bit of a public health perspective because, dental disease is basically a global issue. And we're seeing more and more dental disease in parts of the world where diets are changing, there's more sugar consumption, et cetera. Mm-hmm. A lot more smoking in certain parts of the world. Mm-hmm. So I think thinking broadly about the impact that we can have as oral health care providers when it comes to public health is very important. I would speak to Christina Paston, who's our resident expert in terms of thinking about student wellness and practice of mindfulness and well-being. And she'll relay some very interesting stories about how we as dental providers sometimes don't take care of ourselves in order to take care of others, and that's critical, I think. I think that would be a very interesting perspective. And certainly, in the student affairs area, Dean Gottlieb or Dean Holloway on, what is this next generation of students like? Some of the more specifics about what it takes to get into dental school. And you can get a deeper understanding of, I think, from those two folks.
Yeah, absolutely. That's really, really sage advice. I really appreciate it. So our next guest is actually going to be Dr. Pamela Yellick. For everyone who doesn't know her, she's doing a lot of amazing things in the research side of oral health. And so if you had to sit next to Pamela Yellick, what would you ask her if you were me?
I would ask her, what's on the horizon in terms of her work. She does a lot of exciting stem cell work and so forth. And I would ask her, actually more specifically, at what point does she see what she's doing getting translated into direct patient care? What are the applications?
Yeah, no, I'm really excited to speak with her. So for everybody listening, tune in next month. We're going to be having her on. And thank you so much, Dr. Karimbux,
for been a pleasure.
Joining us and for being our inaugural podcast. For those of you guys who are listening, we would really appreciate you liking and subscribing. We're available on YouTube, on all the different podcast engines, and we will see you next time. Thank you for joining us at Perspectives in Oral Health.